MRI to obviously, due to the localization of the compression, obviously use neuromonitoring intraoperatively. I mean, it's a tool. If it's available, definitely always a good idea in such a case.
Yep.
Yeah, we always do motor.
Just go on.
And
I don't think we can hear you, Chef.
I think all for extremities with motor and sensory.
Yeah. Okay.
Well, I think it's a presentation. What do you think? Okay, so Dr. Hassan, all you. At least I cannot hear you. Attallah, you have to switch on the unmute you.
Okay, yes, you hear me now.
Yes, perfect.
Oh yeah.
Okay.
Finally, it's working.
Start. Yeah, now we were looking forward to your presentation.
Okay, we'll talk about Attallah screw. Actually, there are several known techniques for stabilization of the posterior cervical spine. The most commonly used, and will continue the most commonly used, is the lateral mass screw. The other alternative is the pedicle screw or the laminar screw, which is usually reserved for as rescue technique for fixation of C2 and C7. The main advantages for the pedicle screw, as Dr. Betsin said, is that it's relatively longer in comparison to the lateral mass screw. It provides more stability, more biomechanical strength. The pull-out strength is very high, and it's very useful actually for complex deformities. So surgeons, expert surgeons, prefer to put always pedicle screws when they have very rigid, stubborn deformity where they need a good hold. The main disadvantage is that the learning curve is very high, so not any specialist, I would say not any spine consultant is allowed or will feel comfortable to put a lateral mass screw, a pedicle screw, because of the risk of vascular or neurovascular injury. Mm-hmm. The main problem, from my opinion, is that for us spine surgeons, we can deal with all complications, but having a malpositioned pedicle screw bilaterally, or even at least on the dominant side, will result not only in a mal-placed screw that need to be revised, but with a patient that is not going to wake up after the surgery. So this is a complication, a disastrous complication for the patient and for the family, for the surgeon himself. The lateral mass screw, for the lateral mass screw, we have about 7 published up to now techniques for insertion. I myself, I never saw single colleague who is adhering to one of the techniques. It will be written in the operative reports that he inserted it based on Magel or Harms or Roy Camille or Anderson. But in reality, we spine surgeons will always look for a good bone, enough bone to insert the screw, regardless of the angulation and the degrees. Mm-hmm. The complications what can happen with the lateral mass screw are relatively of low incidence. So even the spine surgeons will relatively not much experience can insert safely a lateral mass screw, at least from C3 to C6. The main disadvantages are you can insert only short screw for unexperienced hands, 10 to 12 millimeter, and the most experienced hand, 14, 16 millimeter long screws. It's relatively safe. Bony purchase is quite low, and you cannot depend on lateral mass screw alone for correction of difficult deformities. And of course, it's difficult to revise intraoperatively. If you break the lateral mass screw intraoperatively, you can forget about that level. This is one example of cases which I call rigid or difficult deformities. This patient has severe kyphosis, known to have neurofibromatosis. He has undergone maybe 12 surgeries up to that point. and he's coming with this severe kyphosis. I myself, I really will feel very unconfident depending on 12 or 14 millimeter lateral mass screw to hold this deformity. So we realize that we have a problem. We need a solution. Why not to find a different screw? If pedicle screw is very dangerous, difficult to learn, serious in unexperienced hands, and lateral mass screw is quite weak, we need an alternative. So we started from the 0 point. We went again studying the human vertebrae, cervical, subaxial vertebrae. We analyzed the anatomical structures, and we noticed that this is the lateral mass. Actually, we have to know that lateral mass by medical definition, it's only the lateral mass of C1. So we say lateral mass screw, but C3s, subaxial vertebrae in general, they don't have lateral mass structure. But we call this bony mass on the lateral side as a lateral mass. So we realized here that this is the pedicle, that's the lateral mass where we insert our screw. And this structure, which is actually the posterior parts of the transverse process, the transformed transverse process in the cervical vertebra, is quite comparable to the pedicle. In some specimens, it's even larger than the pedicle in the length and in the diameter. The idea was why not to use this structure for screw insertion. So this is the normal classical direction of the pedicle screw. This is the direction of the lateral mass screw, and this is the direction of the laminar screw. Here we compared the length of the pedicle, the maximal insertable screw length of a pedicle, to our proposed new trajectory. So our idea was to start between the junction of the lamina with the lateral mass, to go through the lateral mass and pass the whole way through the posterior ramus of the transverse process. In this image, we see the screws, the visual screws, lateral mass, pedicle, and Attallah screw. And you see, you don't need a study to say that the pedicle screw is comparable to the Attallah screw. One more important advantage of the Attallah screw is that we are not limited. You can notice that the lateral mass is limited to the posterior column of the spine. The pedicle screw is going through the posterior, middle, and anterior column, and the Attallah screw is passing through the posterior and middle column of the spine. It's not reaching the anterior column, but it's providing theoretically more biomechanical stability. These are operative findings as an operative Excel showing the lateral mass screw, the Attallah screw, and the good inserted lateral mass screw. So what are the advantages of this technique? Obviously, you have more bony purchase, you are passing through more bony structures, you get more biomechanical stability. The pull-out is very high. When inserting an Attallah screw in one of my patients, and it's not possible to correct it, if you try to bring it out, I'm sure you will break the whole vertebra, because the screw is passing through very, very narrow structure, and it's not easy to bring it out. I never tried to, but I got that feeling when I tried to. The chances of injuring neurovascular structures are relatively low because you are shooting from medial to lateral. You are shooting quite away from the spinal cord. You have it under control, and you are shooting also away from the vascular structures. The stability is quite high in comparison to the pedicle screw. One more important advantage for deformity correction is that you have a very huge space here for placement of bone graft in comparison to lateral mass, where the head of the screw is occupying the whole lateral mass. In case of fracture of the lateral mass, for example, bilateral mass through lateral mass screw insertions, you can insert Attallah screw, and even if the lateral mass break through the insertion, or if it's broken because of fracture, you still have a long pathway to hold the screw. we did our study and we compared Attallah screw with pedicle screw and lateral mass screw. And Attallah screw was quite comparable to the pedicle screw. Actually, to do that, we spent about 4 years collecting adequate, appropriate specimens which can fit to the study. Then we did the preparation. We inserted the screw as usual in the operating theater. When we divided the vertebrae from each other, and we studied every single screw separately. This one simple example where you had the feeling, if I cannot depend in the presence of kyphosis. I believe Professor Besson is one of the most expert surgeons in Germany with dealing with cervical kyphosis. So we decided here to put the Attallah screw. I chose this image just to show you that how huge is the space laterally to place bone graft. And spine surgeons, we believe that screws will hold, but we don't depend on the screws. We depend on the bone effusion. This is why Professor Besson used in the first case the bone graft. In the first case, in the craniocervical junction. There's one more case with tumor. You know, oncological cases, tumor cases are quite different from degenerative. That's true, you can correct it easily. It's much flexible to put screws and put implants and distract, but you don't have the bony strength which will hold your implants. In this case, we decided to do anterior-posterior approach. We did vertebral body replacement, and we combined it with the posterior approach through the screws, and this is the construct at the end. We used Attallah screws in the subaxial spine, and we combined it with the pedicle screws in the upper thoracic and in C7. The goal was to have different screws in different directions so that we get the advantage of the biomechanical stability of this construct to avoid the loosening of the screws in case that this metastasis progressed and destroyed the vertebra above and below. There's one more case with severe degenerative changes and myelopathy. Here was the discussion, should we go from anterior, should we go from posterior? This is always the discussion in spine, and nobody wins. Believe me, don't go on that discussion because we'll never win. The other side will never win. But we had the feeling that the spine is mobile enough. So I started posteriorly. I decompressed the spinal cord. I put my screws. I corrected the deformity as much as possible. Then I went from anterior and replaced the vertebral bodies. This patient is coming regularly to visit me in the clinic. She's very satisfied. She walked like a normal patient. We never realized that she had a huge surgery like this. This is the 3D reconstruction. Again, I combined the pedicle screw here with Attallah screws so that I have a base here for the construct holding and supporting the cervical spine. Because in a previous study, in Carlsbad, we find that even if you were successful in correcting the deformity and stabilizing the spine, the head will still go anterior. So again, it's easier simply because you will start medially, not laterally. For the pedicle screw, you should go very lateral. In patients with a huge head, a huge neck, very obese patients, getting this trajectory, even if you are an expert surgeon, getting the trajectory will be very difficult. And if you are able to get the trajectory with your probing instrument, inserting the screw itself might be a challenge. The other advantage is that it's almost always possible. In one of the cases presented today earlier, there was the discussion of if you should do angiography for every patient before committing the vertebral, the pedicle screw insertion. Actually, books are saying insertion of the pedicle screw is always possible. I believe not, because simply in this case, you don't have a pedicle to insert a pedicle screw. And trying to insert a pedicle screw here on the left side will end definitely with a disaster. It's safer. So you are heading quite away from the neural and vascular structures. We published our cadaver study, our radiologic study, and our clinical study. And in this patient, which I presented earlier, I decided not to put Attallah screw, to put the pedicle screw, not because I don't rely on Attallah screw, but simply because we did not, up to now, we did not manufacture our own screw, and the available screws for the Attallah screw are allowing insertion only of small diameter rod. But if you put pedicle screw, you can use the thoracic and lumbar screws and combine it with a 6 millimeter rod. Thank you very much.
Thank you, Attallah. Wonderful presentation.
Yep.
And the biggest compliment I can give you is that we will continue with your technique.
Thank you very much.
Okay.
Okay. I think we should move on to the next case and discuss the next case, because I think we should finish all the cases and then have a discussion open for everybody. So the next one who's going to present is Dr. Attallah. Are you ready? Dr. Attallah is a board-certified neurosurgeon, and he is particularly interested in spine. Are you there?
Yeah, Chef. Hello, hello zusammen. Hello, everyone.
Yeah.
Do you see my?
Please start with your presentation, buddy.
Do you see my bildschirm, my monitor? I think so. So
At least not yet. Not yet.
Mm.
Screen sharing, and then
yes, I did it. Okay, we'll see now. We'll start then.
then you usually see several screens and select the one with the red frame is the one you selected.